Hi, you guys, and welcome back for another episode of the I Believe podcast. I'm joined with Dr. Carol Shields from Wills Eye Hospital, and today we're going to talk about pediatric ocular melanoma, as well as some of the myths and myth busting around pregnancy and ocular melanoma. So, Dr. Shields, thanks for joining us again.
Yes, thank you for having me. I was going to start with pediatric ocular melanoma if you want me to.
Yeah, I think that sounds like an awesome place to start. Let's just cover some of the current research in pediatric ocular melanoma.
So when we talk about ocular melanoma, we're talking about conjunctival melanoma as well as uveal melanoma. So I'm going to just start with conjunctival melanoma. It's pretty rare to have conjunctival melanoma in children. So when you see a child with a pigmented spot on the eye, it's going to be nevus, 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 and nevus. It's very rarely going to be melanoma. So don't worry. And most nevi occur right at the limbus. They tend to have their onset when the child's 2, 3, 4, or 5 years old. They tend to get a little more pigmented as they head into puberty. And it's a good idea to have them resected just because nevus can transform into melanoma. So if you look at all pediatric conjunctival tumors, only 1% are melanoma, and that's in our practice. So imagine, the real practice, the real world, it's way less than 1%. So I wouldn't worry about it, but it's a good idea to have a pigmented spot on the surface of the eye surgically removed just in case. Now, I'll move on to uveal melanoma. Hey, again, it's totally rare to see uveal melanoma in a kid. If you look at all uveal melanoma, only 1% occurs under the age of 20. And if you look at those children under the age of 20, they're mostly teenagers. And they tend to have approximately the same prognosis as older adults, but I do feel they have a little better prognosis. Why? Because when you do genetic testing of uveal melanoma in children, you're more likely to get negative genetics. That means they're going to be A or B, the Cancer Genome Atlas A or B, which means lower risk for mutation. We found that a long time ago. 10 years ago, we published a report on 1,059 eyes that we did genetic sampling, and we found increasing age correlates with worse genetic mutation. So kids have better genetic mutation or less genetic mutation compared to older adults. So when we see melanoma in kids, yes, it happens. Usually they're over 3 millimeters in thickness. Occasionally they're mistaken as nevus, or could this be retinoblastoma, believe it or not? Or could this be Coates disease or von Hippel-Lindau disease? I mean, there's all kinds of diagnoses that get sent to us. But you can make the diagnosis with a good ultrasound. And if you're not sure, maybe a good MRI, you'll see it enhances. And then you treat them usually with radiation. If you can't, you treat them with eye removal. But we always get genetic testing beforehand because we want to prognosticate for the patients. And for example, today I saw like a 12-year-old girl who had a small ciliary body melanoma. We did genetic testing. It was the Cancer Genome Atlas Group A. I was able to tell her, hey, that's low risk. You're likely to do fine long term. You're doing well. We'll keep a check on you once or twice a year. So keep in mind that melanoma of the uvea can occur in kids, but generally, and believe it when you see it, and send them. If you're not sure, send them to an ocular oncologist to look and make a diagnosis. You never want to presume anything in a child. You don't want to presume retinoblastoma. You don't want to presume Coates disease. You want to be 100% sure. Is it melanoma or is it not melanoma?
So are there any current specifically pediatric treatments that you're aware of that are just unique to the pediatric realm? And if not, then do you have hope that there would be some level of, for example, maybe the Belsar drug that you mentioned, something that could help to preserve vision? Because I'm sure for a younger child, preserving the vision as well as the life is also higher on the list because they're so much younger.
Right. Today we had a 5-year-old child who had a big ciliary body melanoma, but he had ocular melanocytosis. So that's what promoted his risk for melanoma at such a young age. He required enucleation. But one thing about kids is kids just have a more robust system, body. They respond to things more robustly. And the same thing is they respond to radiation more robustly. When you put a plaque on their eye, they're at risk to get worse radiation retinopathy. So for kids, I think it's really important that we give them the prophylactic anti-VEGF Avastin and that we put in a mini sector PRP to reduce their VEGF drive, because their VEGF drive is going to be powerful, much more powerful than an 80-year-old VEGF drive. So we always watch these kids really closely and make sure we don't miss any treatments to reduce the VEGF drive. Yes, I do think you mentioned Belsar down the road. Belsar would be one heck of a good treatment for a small melanoma in a child. You know, if you have a small melanoma, it has, say, 3 risk factors. You know the child's going to have a 34% chance for transformation into melanoma with growth. Yeah, we could treat that child with Belsar and hopefully protect the vision and hopefully, cure the cancer and put it to sleep. But, time will tell, and we have to get Belsar FDA approved. Right now, we can't treat anyone under the age of 18. Yeah. With Belsar.
And I know that's definitely one of the things in the pediatric ocular melanoma community that kind of rubs, because those parents are like, well, we want these clinical trials, whether it's for metastatic treatment, for adjuvant treatment. We want these trials available for the kids because we want them to be okay too. Yeah. So I feel like it's so reassuring to hear you talk a little bit more about the genomics of the tumor and how kids have a much better chance of having those better prognostication factors. So that was really helpful. Is there anything else you want to say to pediatric?
Yeah. So, I can say a few words on, retinoblastoma and how we have completely changed retinoblastoma in the past since 1994 using chemotherapy. Awesome. And I think we're on the cusp with uveal melanoma. I really think in the next few years, things are going to shift. But right now, with retinoblastoma, we can cure the child. We can save the child's life. When I started, there was a 20% risk for metastatic disease with retinoblastoma. Now it's 1%. In our hands, it's less than 1%. Kids just don't die from this cancer. And we prevent the disease from transmitting to the next generation. Isn't that cool?
That's so novel. That's so cool.
Because retinoblastoma is, in 1/3 of cases, a heritable disease. So now what we do is we do in vitro fertilization, and we only fertilize the female with fertilized eggs that do not carry the mutation. So the transmission stops with the next generation.
That's incredible.
I remember taking family trees back in the 1980s when I was just starting, and Aunt Elsie died of retinoblastoma at age 2. Uncle Morton, he died at age 5 from retinoblastoma. And then my mom had it and she survived and she had me. That's going to all be done. Yeah, so we've done a lot with retinoblastoma. And you mentioned, we need FDA approval. Well, we sort of don't have any FDA approval for any of the drugs we use in retinoblastoma care. We don't have any approval for the use of vincristine, etoposide, carboplatin, melphalan, topotecan for retinoblastoma. We're using it all in kind of a sympathetic way, and we know it works. And we've done enough trials to show that it works, but we don't have FDA approval. We're just using it because it's been shown, thanks to Judy Kingston in London, who first did it, and thanks to Kaneko in Japan, who first did IAC. We learned those drugs work. We started using them. There's no FDA approval, and kids have lived enormously, thanks to some great observers who contributed to the field. So I think even though Belsar might not be approved for use in under age 18, we could probably use it in a sympathetic way for young patients.
So you mentioned a little bit of some of the changes in retinoblastoma helping to lead to this kind of cusp of research for the way that you treat uveal melanoma. Do you want to touch on that a little bit?
Yeah, so, back in the day in 1994, when Judy Kingston from St. Bartholomew's Hospital in London, England, made an observation. She said, I treat neuroblastoma with VEC, vincristine-etoposide carboplatin. Maybe I'll use that for retinoblastoma. She did, and she saw dramatic response. So all of us in the U.S. heard about this, and all three of us in North America started using it, and it was scary because we would put these kids on systemic chemotherapy, never knowing what we were going to see in the operating room. A little bit worried that, some kids might get worse, but on the contrary, almost everybody got better. And now we're saving more eyes than ever. Only 5% of kids now require enucleation, and only 1% develop metastatic disease. And the whole world of chemotherapy, whether we give it intravenous, intra-arterial to behind the eye, or inject the vitreous or inject the aqueous, so many eyes are saved, and kids march out of this hospital so happy and parents so proud that their child is doing well. So today I saw a family from Wisconsin. I treated their young boy when he was 4 years old. He had advanced retinoblastoma. We gave him intra-arterial chemotherapy, intravitreal chemotherapy. He's now 16 years old, driving a car. He has no recurrence, and he's doing awesome. And he still has his eye. And he's a very neat little guy, young guy, very thankful that he has his life and his eye, and he has some vision out of that eye. This is how the whole field of retinoblastoma has been flipped. And I do think we're going to see a similar, maybe slower flip for melanoma, because we don't get answers with melanoma as fast as we do with retinoblastoma. Retinoblastoma, you get answers in a month. If a treatment is not going to work, you're going to know in a month. Hence, we always see these kids back when we're doing a new treatment 1 month later. With melanoma, you usually don't get answers like for 4 months or 6 months. So it's going to be a little bit slower to get some of the results. We're poised to have a lot of new therapies, and we're poised to have kind of a game changer now with uveal melanoma. And, I think it's going to impact pediatrics as well as adult uveal melanoma.
Thank you so much. Let's shift gears a little bit. This is maybe a hot topic for some of our younger ocular melanoma adults. We have many patients in the community who worry about future pregnancy or worry about whether or not pregnancy has a risk for, causing metastases or just any of those kinds of things, as well as the risks around being pregnant while you're being treated with ocular melanoma. So do you want to just talk a little bit about some of the myths versus the facts around pregnancy and ocular melanoma? Let's just start with primary treatment first.
Yeah. So uveal melanoma can definitely occur in younger patients, and it can occur during the years when pregnancy is possible, and it can occur during pregnancy. But we don't think pregnancy has any impact on the development of uveal melanoma. Uveal melanoma most often occurs in fair-skinned people. We call that Fitzpatrick skin type 1 or 2, like you and me, fair-skinned people. And pregnancy does not lead to the development of uveal melanoma. That's a myth. And pregnancy does not portray or cause a higher risk for metastatic disease. That's a myth. The one thing that's a truth, a patient who's pregnant tends to retain more bodily fluids. And when they have a melanoma in the eye, they tend to have more fluid. with the melanoma in the eye. That's okay. The fluid goes away with treatment. No big deal. But they're not going to get any higher risk of metastatic disease than a non-pregnant person. Now, how do we know this? Well, we did a study on this many years ago. I think it was, again, in the 1990s. We looked at, I think it was 16 pregnant patients and compared them to non-pregnant patients in the same age group. And we found that they had the same incidence of metastatic disease. Then Dan Albert, when he was up at Mass Eye and Ear, he looked at pregnant patients who had uveal melanoma who were pregnant and came to enucleation. He looked at surface markers on the melanoma. Do they have estrogen or progesterone receptors that maybe the progesterone going up in pregnancy led to the development of melanoma? And he said, no receptors. So they don't have normal receptors that are found in pregnant women.
Okay.
So we really don't think pregnancy has any impact on the development or the risk for metastasis of melanoma. However, if a pregnant patient has a melanoma, we try not to irradiate during the first trimester because we don't want to expose the fetus to any radiation. If we have to irradiate, we will have the mother wear lead the entire time she has radiation on. So we give her our lead vest and a lead skirt. So that way the radiation to her eye can't penetrate the lead vest. So it's not going to get to the fetus. And we do everything, all of our surgery under local anesthesia, no general anesthesia. Even if she's in second trimester and even sometimes in third trimester, we still do the lead vest on the mother, just for peace of mind, you know. So when we come in with our Geiger counter to check for radiation in a patient with melanoma, if we're this far away, we usually can't detect it an arm length. But as soon as you get a little bit closer, like a fist length away, you can detect it. So imagine you're only going to detect a little bit of radiation in this aura about the size of a head. And the radiation does not cause any damage to the opposite eye, to the brain, to the mouth, to the sinuses. So it's so minor that it's not going to cause any risk to the fetus. But we still, just for peace of mind, put a lead vest and a lead skirt on the mom. And in the past, and we sometimes still do this, instead of having the mom wear it heavy on her abdomen that's already big, we put that, you know, in a hospital, how you have like the dinner tray, that little moving dinner tray, we put that over the mother and we just lay the lead on top of that so that it's not on her abdomen, it's on the dinner tray. So it can't go through that. But a lot of it is myth and not fact. This year at the Academy, though, I am giving a talk on ocular oncology and pregnancy. And you know what I'm talking about? Basically, two things. Yeah, I'll talk about melanoma, but I'll say it's mostly myth. But with choroidal hemangioma, a pregnant woman gets lots of fluid. So choroidal hemangiomas can get worse during pregnancy. So if you have a choroidal hemangioma, it might become more leaky during pregnancy. And what do? We usually wait for the patient to become unpregnant because the fluid tends to go away. I'll never forget, 20 years ago, I had a Hispanic lady who had a choroidal hemangioma. She had total retinal detachment. And we said, let's sit tight till she delivers the baby. She delivered the baby, all her fluid went away. Because all that fluid that you retain goes away. So it's good to wait on that. The same with meningioma. That's the second tumor. Meningiomas, if they're in the brain or around the nerve of the eye, They can get worse with water retention during pregnancy, but then that goes away once they deliver the baby.
I think as far as pregnancy and uveal melanoma goes, I think hearing you talk about some of those studies that you shared around just showing that we don't see any of those risk factors for progesterone or estrogen, showing that pregnancy would exacerbate, say, metastatic growth or the primary tumor growth. That's hugely reassuring. And I'm sure that the people listening, we can share that with our friends just to make sure that they know. There's so many ways and so many things that, especially when we're a younger patient, that ocular melanoma, uveal melanoma can just feel very scary and uncertain.
Right. And bottom line, early detection makes a difference. Really important.
So you mentioned not treating in the first trimester. So if you find something that is early, like a small nevus, let's just hypothetically speak here, would you still want to wait for a couple of months? Do you have that kind of window of time to work with the first trimester versus the second in a pregnancy patient?
Yes, we have so much better treatment options. We have so much more freedom for treatment second and third trimester. First trimester, we really want to be super careful with the fetus because, cells are dividing into the liver, into the eye, into different organ structures, and we don't want to disturb any of that. So if we saw a choroidal nevus that was a bit suspicious in the first trimester, we would probably bring the mother back in, say, 2 to 3 months, hopefully get them into the second trimester. And then if we needed to do treatment, whether it be low-dose plaque radiotherapy or standard-dose plaque radiotherapy versus maybe transpupillary thermotherapy, we would do it.
Okay.
But we feel so much more freedom in the second trimester. And of course, much more freedom. By the time you get in the third trimester, most of the organ systems are already developed. It's mostly just growth of the organ systems at that point.
This has been so neat to listen to. So Dr. Shields, I'm so thankful to you, so thankful for your expertise. And we here at A Cure in Sight and through the I Believe podcast listening community are so grateful for everything that you've shared and just the continued efforts that you and your team make in research, in training the next generation of ocular oncologists. I know that you do a lot of medical teaching with your fellows and your students. So we are so thankful for everything that you do for the ocular melanoma community every single day.
Well, thank you. And our whole team feels honored. I couldn't do this without all of the technicians and the front desk, back desk, counselors, you name it. We all work together as a team. It's not just one person taking care of the patient. It is really an entire team. And for us, it's a great honor, and we will continue to strive to do our best.
Well, for those of you listening, please make sure to share this episode with any of your friends and anyone else in the ocular melanoma community. And we are so delighted to have Dr. Shields here. We hope we'll get to have you back at a future date, maybe to talk about something new or something a little more specific. Maybe we could talk about Belsar, or we could talk about Darrow a little bit more in depth. But it's been such a pleasure, and we look forward to having you back next time.
Great. Thank you, Danette. This was really a fun conversation. I really appreciate it.